Good evening. So let's start our lecture today as we continue our lecture on mechanical ventilation. So we'll start with weaning off from the ventilator. We said the last lecture we had that before a patient is connected to the ventilator, you must ensure that the indication for the mechanical ventilation is reversible. Therefore, it's important for us to wean the patient off ventilator. And weaning off the ventilator refers to a period of transition from total ventilatory support to a period of spontaneous breathing. Early weaning is advocated because it reduces the risk of ventilator-associated pneumonia, ventilator-induced lung injury. It reduces length of stay in the ICU and reduces overall morbidity and mortality. So weaning off the ventilator actually starts from the very day you put the patient on ventilator.
Press.
Weaning off the ventilator Weaning off the ventilator has two components. Number one, it's liberation from the ventilator. The first step is to liberate the patient from the ventilator, and the second component is extubation. So there are two components. You liberate the patient off the ventilator, and you successfully extubate the patient. Failure of both or either of the two constitutes what we know as failure to wean. All right, and there are some reversible causes for failure to wean. So failure to wean from the ventilator is either failure to liberate this patient from the ventilator, or the need to return the patient to ventilator within 24 to 48 hours, or the need to re-intubate the patient. So failure in each of these two components qualify for the definition of weaning off, failure to wean. And so what are the steps to weaning from the ventilator? Number one, you need to confirm patient's readiness to wean. Is this patient ready to wean? And I devised a very simple way, all right, to confirm patient's readiness to wean. I call it G-host. It used to be ghost. I used to call it where the patient is no longer a ghost. And it sounded offensive to some people, so I made it G-host. All right, so be 2018. All right, mnemonics. The G is when the GCS, because GCS has improved at least 13/15. Patient is now hemodynamically stable with mean arterial pressure greater than 65 millimeters of mercury, and the patient is no longer on inotropic support. Oxygenation has improved as evidenced by FiO2 less than 0.5, SpO2 greater than 90%, respiratory rate less than 35 cycles per minute. PIP is now less than 10 centimeters of water. Tidal volume is greater than 5 ml per kg, and vital capacity is now greater than 10 ml per kg. So objective indications to show that oxygen has improved are the things I've outlined here. All right, the S is spontaneous breathing trial. All right, this patient must have passed spontaneous breathing trial, and the commonest index that is used is the Tobin's index, also known as rapid shallow breathing index. All right, when the rapid shallow breathing index is less than 100, all right, per minute per liter, it shows that this patient has passed the spontaneous breathing trial. And it's so easy to do. You connect the patient to a T-piece for 2 minutes and you calculate the frequency of a tidal volume in liters. All right, sometimes you can give an allowance of between 10 to 20, all right, in the Tobin's index. Sometimes higher Tobin's index does not mean the patient cannot be weaned off ventilation. Sometimes the patient may be anxious. And what I do sometimes is to give the patient a bit of anxiolytic and redo the test. All right, so the patient must pass the spontaneous breathing trial or the rapid shallow breathing index. The T is that the patient must be apyrexia temperature less than 38 degrees Celsius. All right, the second step is now the patient is ready to be weaned from the objective assessment we just mentioned. You want to go to step 2. And number 2 is that you want to stop sedation to wake up the patient. All right, this is important. And sometimes if you use muscle relaxant, you want to antagonize residual muscle paralysis. You stop sedation and you communicate with the patient. This is critically important. Like I keep telling everybody, you talk with the patient, you communicate and reassure the patient. You explain what you are going to do for the patient. All right, and the patient that patient is awake, he should follow your command. Then you record baseline parameters, the patient's parameters, heart rate, SpO2, blood pressure, and all that. Then you reassess the patient again for spontaneous breathing trial and ensure that the patient has passed the spontaneous breathing trial. Step 3, you want to now go into, will this patient be able to maintain his airway? So step 3 is now ensuring adequate cough reflex is present. All right. You want to suction secretions from the tubes to ensure airway patency, and you want to do a cough leak test to be sure that this patient will not go into post-extubation airway obstruction. And once you are satisfied with all of this, you may safely proceed to extubate the patient. Now, so this is a flow chart that I find very useful. All right. Number 1, ready weaning. Are you ready to go? All right. As the patient passes the G-host criteria, the patient is breathing, ready breathing. Then ready extubation. The parameters are there. So you can look at the flow chart. Reason for ventilation has improved or resolved. All right, daily speed of respiratory function. All right, if no, continue ventilation. All right, if it's yes, you proceed to your spontaneous breathing trial. All right, sometimes people say between 30 minutes to 120 minutes. All right, on your T-pace. If it's well tolerated, you proceed to extubation. Well, if it's poorly tolerated, you want to do gradual weaning, daily T-pace trials of pressure support ventilation. All right, proceed to extubation if spontaneous breathing trial is well tolerated, and you want to extubate, respiratory failure post-extubation. All right, you want to intubate if appropriate, or you want to consider trial of non-invasive ventilation. All right, so this is a very useful flow chart for weaning of mechanical ventilation. All right, there are different modes of weaning. Like I mentioned before, the first one is the spontaneous breathing trials. All right, where the machine support is gradually withdrawn, and a T-piece or a simple circuit can be attached intermittently for increasing periods of time. This allows the patient to gradually take over the work of his or her breathing with shortening rest periods back up of the ventilator. So you start with 30 minutes. If the patient passes that, all right, you go to 1 hour and then about until you are sure that the patient does not need backup ventilation. Using the pressure support weaning mode, all right, in this group, the patient initiates all the breaths, like our PSB, all right, and these are boosted by the ventilator. How you wean off this patient is you gradually reduce the support, the pressure support that the ventilator is given, all right, making the patient to assume responsibility for his or her own breathing. Once you achieve a pressure support that is as low as 5 to 10 centimeters above PEEP, you can proceed to a trial of TPs or simple weaning, as the case may be. All right, I put this few slides here to show you the specific ventilatory consideration in some clinical conditions. The first one is ARDS. All right, we know that a number of our patients come down with ARDS after some times, all right, in the ICU, or some can even come primarily with the diagnosis of ARDS. So the goal of ventilation here is you want to provide adequate oxygenation and ventilation while you are minimizing further lung injury. Let me repeat that again. The goal of mechanical ventilation in ARDS is to provide adequate oxygenation and ventilation while you are minimizing the risk of lung injury. The following settings are commonly used. You want to give tidal volume, low tidal volume, or lung protective tidal volume, about 4 to 8 mils per kg. All right. Some people do 4 to 6. Or some people do 6 to 8. All right. So, but you must do the ideal body weight. You need to calculate the ideal body weight. All right. I hope we all know how to calculate that. All right. Is for male is 50 plus 2.3 times height in inches minus 60. All right. Ideal body weight is 50 plus 2.3 multiplied by height in inches minus 60. All right, that is ideal body weight, and that's what you should use in deciding on your tidal volume. Respiratory rate should be between 20 to 30 breaths per minute, and your PEEP can range from 5 to 15. Some people have used higher PEEPs, all right? And you want to adjust your FiO2 to a point where you maintain at least saturation above 30. By all means, the plateau pressure for ventilation in ARDS should be less than 30 centimeters of water. In chronic obstructive airway disease, all right, the important thing is that mechanical ventilation may be required in cases of acute exacerbation. Most times, COPD can be safely managed with your non-invasive ventilation. But when there's an acute exacerbation of COPD, you want to do invasive ventilation, all right, with a training volume 6 to 8, respiratory 10 to 20, and the PEEP 5 to 10. You want to maintain your FiO2 to a saturation SpO2 of greater than 90. Plateau pressure should also be kept below 30 centimeters of water. In severe asthma, we can have some exacerbations that will require invasive mechanical ventilation, and it's almost the same with that of COPD, except that the respiratory may be a little higher. Sometimes we manage traumatic brain injury, and they require some specific modifications of their ventilatory requirements. But the goal is to maintain adequate oxygenation and ventilation to prevent secondary brain injury. Sometimes mechanical ventilation may just be a mode or a means of actually managing or treating raised intracranial pressure. So tidal volume ideally should be between 6 to 8 mils per kg of predicted ideal body weight. Respiratory rate should be between 12 to 20. The aim, you want to prevent hypoxia, and you want to also prevent hypercapnia. Inspiratory time should be between 0.8 to 1.2 seconds. This is to allow adequate time for expiration and prevent dynamic lung hyperinflation. A positive PIP of 5 to 10 centimeters of water is generally recommended in patients, and you want to maintain SpO2 between 92 to 95%. Don't forget head of bed elevation to 30 degrees, because this also helps to reduce intracranial pressure and improve cerebral perfusion. All right, so let's go to non-invasive ventilation. This is another mode of ventilation, another mode of positive pressure ventilation. So ideally, it should be positive non-invasive ventilation. All right, this requires a means of delivery of mechanical ventilation without endotracheal intubation tracheostomy. This ventilatory mode was initially used for patients who are hyperventilating, resulting from neuromuscular disorders. But it has also been very useful in the early management of acute respiratory failure. It has several advantages, so does it have disadvantages also? The NIV is easy to implement. It ensures patients' comfort. All right, there's reduced requirement for sedation. Patients can speak, swallow, and even cough, which improves quality of life in the ICU. All right, also avoids the obvious complications of endotracheal intubation. It reduces the cost of care. It has also been found to reduce hospital length of stay. However, some of these disadvantages include, the slowness to correct respiratory failure. There are a lot of air leakages. By the time we go to equipment, we will see that it can lead to ear irritation, facial skin necrosis. And in some patients that you are giving non-invasive ventilation, they could lose the airway. And since you don't have access to the airway, that can be catastrophic. Some patients can't tolerate NIV because they're claustrophobic. And in this patient, you require increased need of supervision. Now, patient's interface, since we said that this is delivery of positive pressure ventilation without endotracheal intubation tracheostomy, we have different types of patient's interface that are useful or that are helpful in the patients being given the non-invasive ventilation. So mask, a lot of times oral nasal mask is the best. All right, you can see them at the left side of the slide. All right, we can have one that covers all the face. You require pillows, mouthpiece, and helmets to help this patient. So these are some of the patient's interface. What would mean that non-invasive ventilation is actually, the ability to manage the patient, the patient interface, and the ventilation. Those are the three key components of non-invasive ventilation. There are different modes of non-invasive ventilation. You can see this patient, all right, who is being offered continuous positive airway pressure. All right. Now, what this does, the CPAP machine that is lying by his bed provides constant positive airway pressure throughout the patient's respiratory cycle. It is primarily indicated for the management of hypoxemia, all right, as it improves oxygenation and decreases work of breathing. So it's indicated for patients with COPD, patients with congestive cardiac failure, patients with pneumonia, ARDS, early stage of ARDS, or asthma, and there is also indicated in patients with cardiogenic pulmonary edema. We have the B-level PAP, all right, B-level positive airway pressure. As you can see the difference, there's a difference between CPAP and BPAP. In BPAP, this is indicated for both the management of hypoxemia and hypercapnia. We did say that CPAP is indicated for the management of hypoxemia, but BPAP can be used for the management of both hypoxemia and hypercapnia, because it has the inspiratory positive air pressure and the expiratory positive air pressure. Initially, you want to give the expiratory positive air pressure between 4 to 6. All right, and as you go on, you want to increase it as the patient tolerates it. Your EPAP, expiratory positive air pressure, should be started lower, maybe 2 to 4, while for IPAP is about 4 to 8. And you wait for the patient to trigger the ventilator. By the time you trigger it, then the patient, the IPAP and the EPAP may increase. It's indicated in cases of acute respiratory failure, COPD, and asthma. All right, so these are the differences, comparison between BPAP and CPAP. All right, is BPAP and CPAP are continuous pressure, but for BPAP, the pressures are different between inspiration and expiration. All right, the maximum is between 12. The difference for inspiration pressure applied to inspiration is 12, that is maximum, and for expiration, maximum is 8. BPAP is not commonly used in the field or at home due to the complexity of the delivery and the devices. It also requires more intensive monitoring, especially of the delivered pressure. It's cheaper than CPAP. For CPAP, it's a constant pressure that is delivered throughout expiration and inspiration. It's less complicated and can be used in the field or at home. All right, it needs little monitoring. And this is the CPAP we saw with this patient. Okay. So if you are asked what is the difference between BPAP and CPAP, I'm sure you can just produce for me. All right, like I said before, non-invasive ventilation can be used for exacerbation of COPD. And this is a slide to just show you how it is done. All right, and also non-invasive ventilation for left ventricular failure, especially complicated by cardiogenic pulmonary edema. So starting off the NIV, all right, you want to do appropriate patient selection, all right, which is important. You can have a good machine, you can have a good personnel, but if your patient is not appropriate, all right, or the ventilation is not appropriate for your patient, you won't help the patient. So patient selection is key, all right? So you want to look at the diagnosis. What is this patient diagnosed with? Patient with COPD, all right, cardiogenic pulmonary edema, ARDS, patient with pneumonia, and your vascular disease are candidates for NIV. All right, you want to look at the severity of respiratory failure. NIV is only indicated for mild to moderate. When the respiratory failure is becoming severe, it's an indication to change from NIV to invasive ventilation. All right, you want to look at the patient. Is the patient alert or cooperative? All right, you don't want to use NIV for patients who are comatose, who are not cooperative. Is the patient hemodynamically stable? Patient with severe obesity and patient with facial trauma are not candidates for non-invasive ventilation. All right, the equipment sections, the commonest one is the BiPAP that is used in some hospitals. Appropriate mask should be tight-fitting. All right, tubing should be long enough to allow the patient to move around in bed, but be careful of leakages, airway leakages, which is common in this group of patients. Filters should be replaced regularly. This is to prevent infection. And you also have humidifier as part of your components of your equipment. This helps to humidify the inspired air and prevent drying of mucous membrane. They are also reducing the risk of infection. Also, your delivery system, this can be done through the BiPAP machine Or you can actually give this patient directly through the nasal route. So before you start, you want to ensure there's no contraindications, some of which I've mentioned. You want to obtain a baseline ABG and other results like your electrolyte. Then you commence oxygen therapy with this patient before you connect them to the CPAP or the BPAP machine. You want to explain your procedure. It helps to reduce anxiety and it helps to tolerate the machine. You want to select appropriate mask size. Then the ventilator must be set in either spontaneous or time mode. All right, the ventilator must be set in spontaneous because the patient is breathing. You must hold the mask in place, reassure the patient again and fix the mask. Start with low settings of the IPAP 6 to 8 centimeters of water and EPAP of between 2 to 4 centimeters of water, and give oxygen as low as 2 liters per minute. Then you monitor and regularly observe the patient as it improves or not. So like I mentioned before, patient assessment, I mentioned this. Contraindications to non-invasive ventilation: patient who is unconscious, inability to protect the airway, patient is hemodynamically unstable, patient with pneumothorax, bowel obstruction, patient with facial trauma, and excessive secretions. These are contraindications to the use of non-invasive ventilation. Monitoring continuous pulse oximetry. You want to measure the exhaled tidal volume to ensure that it's adequate. ABG initially, then at 1 hour after connection, then you can do it 6 to 6 hours later. You want to ensure that the chest is moving and the respiratory rate is adequate. You also want to measure the vital signs. You want to look at the mental state of the patient. All right. Also observe for respiratory effort and patient's comfort. All right, how do you know that you are not winning? How do you know that your NIV is failing? If there is deterioration of patient's condition, either clinically or by laboratory technique, your ABG is not improving or actually maybe worsening, a patient who is not tolerant of the NIV. So what you need to do is that you want to check patient's ABC parameters, optimize medical treatment. For instance, if the patient has pneumonia, you want to give antibiotics to ensure that medical treatment for this patient require NIV has been optimized. And there are other complications, just like any medical procedure. You want to look out for any complications and treat them. Okay. Now, when do you discontinue? Okay, there's a time to discontinue. When the patient is no longer able to tolerate the mask, the interface, when the gas exchange is not improving, now there's a need for endotracheal intubation. All right, patients becomes hemodynamically unstable, despite being on NIV, or you can have arrhythmic or ischemic changes on your ECG. These are criteria, absolute criteria to discontinue with NIV. Now, there are two things there: discontinue and withdraw. Withdraw is when your patient is doing well and there's evidence of clinical improvement. Okay, you want to stop or withdraw the patient. So you must aim for respiratory rate of less than 24 cycles per minute. Heart rate must be less than 110 beats per minute, and the pH must be at least greater than 7.35. SpO2, you should be able to achieve SpO2 of 90%, greater than 90%, or 0.4 FiO2. All right, when this is consistent for 2 hours, you may want to withdraw your patient from NIV. There are a lot of complications. People on NIV may become hypoxic. you could have barotrauma. All right. There could be reduced cardiac output from your respiratory pressure, respiratory positive airway pressure. Patient may vomit or aspirate. And this is terrible because the airway is not protected in this mode of ventilation. You also ensure that there are no pressure sores and the stomach is not distending with the positive airway, positive air that is being pumped to the patient. All right, so ventilator waveforms is not part of your lecture, but I felt I should just mention it to you. Ventilator waveforms are very important because they can be very diagnostic. They can help with diagnosis. All right, ventilator waveforms are graphical descriptions of how a breath is being delivered to the patient by the ventilator. All right, so we have two major types of ventilator waveforms. We have the scalar and the looped waveforms. All right, for the scalar represents a plot of either pressure, volume, or flow versus time. The time is always on the x-axis. But when either pressure, volume, flow are plotted against each other, it gives a looped waveform. Okay, so now look at this. These are examples of scalar waveforms. How do I know that? Because the time is on the x-axis. Okay, so we can either have volume, pressure, or flow on the y-axis. And there are different types of waveforms. We have the square waveforms, we have the ascending ramp, the descending ramp, the sine waveform, exponential rising, and exponential decay. These are types of scalar waveforms. Now, so pressure waveforms, many of us, I want to advise us once we finish this lecture, go and interact more with your ventilators because you'll see all of this there. So if you are looking at the pressure waveforms, you see that pressure waveform is a square waveform, square. All right, it gives an exponential rise and is sinusoidal. All right. The flow waveforms gives you a descending ramp. All right, it's square, shows that it's constant, but it gives an exponential decay and sinusoidal. You can also have an ascending ramp in your flow waveforms. It depends on the mode of ventilation. All right, volume waveforms is always ascending, ascending ramp and sinusoidal. Sinusoidal waves actually seen with spontaneous and unsupported breathing. Okay. So if we look at flow versus time scalar waveform, flow versus time, the flow is on the y-axis, while time is on the x-axis. So it gives you a flow versus time waveform will give you a square wave. All right, it can be ascending and descending, ascending on the left and descending on the right. So it has a decay flow. But what you get actually depends on the mode. Like I mentioned before, the ventilatory mode. If the patient is on pressure control mode, remember that the pressure control mode or flow time waveform is always decelerating. All right, the pressure goes up and comes down, so it gives a decelerating pattern. And this waveform cannot be changed. All right, you remember in pressure control, Maybe you tell you it's pressure limited. Maybe your inspiratory pressure, you set it at 25 or 30. This cannot be changed because it's already been set. In volume control, the flow versus time waveform can be changed depending on the ventilator options. All right, and it also gives you different types of waveform as it changes. The next one is okay. I'm sure we all see this in our anesthetic machine. Maybe we should pay attention to it. Try and put your machine on volume mode and see on pressure mode. Okay. For the volume control NIV, you can see the pressure here, the flow, and the volume. All right. Why for pressure control, like the pressure regulating or pressure reducing volume control, PROVC, the waveform is different. So just familiarize yourself as you go to theater tomorrow or the ICU, you can look at the different waveforms. So if we look at the different waveforms, the square waveform is actually the inspiratory time is shortest. And the reason this is important is because you can use this to diagnose a lot of ventilator patient interactions. For the square waveform, the inspiratory time is shortest. All right, why the highest peak inspiration, it has the highest peak inspiration. For this, the square waveform is better, all right, for hemodynamically unstable patient because it allows for better venous return and cardiac output. For the descending ramp, initially, if it's not fixed, the inspiratory time is increased, all right, until it gets a peak inspiration flow. Then what happens is that it gives you the least peak inspiration pressure. So for patients that you don't want to have barotrauma, for patients ARDS and the rest, you want to have a descending ramp. Here you are bothered more about oxygenation because it gives you a high mean airway pressure, which helps lung inflation and oxygenation at the end of the day. The sinusoidal and ascending waveform, all right, the initial flow rates are slow, all right, and this causes what we call flow starvation because the patient is not getting enough flow, all right, but this kind of sinusoidal and ascending should not be used in assist mode, all right, that you allow the patient to take a break, but the patient will have what we call flow starvation. But the descending ramp and square waveform can be combined together, all right, which decreases here hunger because it ensures that there's adequate flow to the patient initially and reduces as the tidal volume is reached. All right, decelerating flow waveform has a lot of advantages because it decreases peak inspiratory pressure. It's better for oxygenation as it increases or decreases the AA gradient and improves patient ventilator synchrony. Some of the disadvantages are it decreases respiratory time and it leads to auto PEEP with breast stacking. All right, this can increase mean airway pressure, therefore reducing venous return and cardiac output, unlike the square waveform that we looked at before. All right, because of the increased pressure, it can also lead to increased intracranial pressure, which makes it disadvantageous in patient with traumatic brain injury. All right, if you look at the pressure versus time waveform, All right, you'll see that, it starts like this. It's like a P. All right, like a P. I like to use that also. This is the pressure at 5. It gets to the maximum at the peak inspiration pressure and begins to plumb down. It gives you, this is a plateau pressure, all right, which is a shift, a transition between inspiration and expiration. So between inspiration and expiration, there's a plateau pressure, all right? And this is set at a PIP of 5. So you see that the pressure versus time scalar waveform, all right, the baseline is always at a PIP. All right, this is volume versus time. What can you get from a graph of volume versus time? The tidal volume is always on the y-axis. All right, expirating leak will fall, so we fail to return to the x-axis in air leak. And that's why I was saying that you can use your ventilator waveform to make some diagnosis and helps your management. When the expiratory limb fails to return to the x-axis or to the baseline, it's an evidence of air leak if you're using the volume time waveform. All right? If there's active expiration beyond what is expected, you see that the graph continues beyond the baseline. All right, if the expiratory limb also fails to return to the baseline, there's autopy because there's air. All right, instead of alveolar empty, there's air at the end of expiration. Yeah, so the loop waveform is very important, especially as it's very, we are conversant with was a bedside lung function test. But for ventilator, it's the opposite. All right, here the inspiratory curve is upward, while the expiratory curve is downward, which is opposite to your normal spirometry tracing. So the loop waveform, the pressure volume loop forms, is as presented on the right side of the slide. All right, the volume is plotted on the y-axis, while pressure is on the x-axis. Like I mentioned, the inspiratory curve is upward, while the expiratory curve is downward, which is different from what you see in inspiratory graphs. Spontaneous breath go clockwise, while positive pressure breaths go anti-clockwise. The bottom of the loop is set at PEEP. All right, so therefore will be 0 if no PEEP. If no PEEP is applied, it will be 0. Area to the right of an imaginary line drawn from the middle of the loop represents inspiratory resistance. So you can see that there are a lot of informations you can derive. All right, so it's important for us to just familiarize ourselves with these loop forms. Flow versus volume. Okay, this is what looks more like the spirometry loop waveforms. All right, you can see that the flow volume loops are similar to those used for pulmonary function tests or lung function tests, but it's usually upside down for this. All right, inspiration is above the horizontal. You can see that, while the expiration is below. For pulmonary function test or lung function test is the other side. The expiration is above, while the inspiration is under. The shape of the inspiratory curve matches what is said on the ventilator. Look at it. This is the inspiration, all right? And you see that it corresponds usually to what you said on the ventilator. Flow volume loops can be used to determine peak inspiratory flow, peak expiratory flow, and tidal volume. So it's important for us to just remember its uses. All right, so how to use the graphs for diagnosis of disease states. I want you to just interact with it and see how you can pick it up. For instance, a patient with increased airway resistance. On the pressure time waveform, which is one of the scalar waveform, you see that there's an increased difference between the peak pressure and the plateau pressure. So there's an increase, but you find out that the plateau pressure is the same because at this point there is no added pressure, but there's a significant increase between the peak and the plateau pressure. The peak pressure is higher because it's trying to overcome whatever resistance. All right, for airway resistance in expiratory flow waveform, this leads to a decreased peak expiratory flow rate. All right, there's an increased expiratory time because don't forget that expiration is always passive, so it takes longer time to overcome the obstruction, the resistance. All right, for the volume time waveform, the expiratory limb is usually longer than the expiratory limb when you have cases of increased airway resistance. All right, if there's decreased compliance of the system, whether of the thoracic cage or the lung parenchyma, all right, you will see that there's increased plateau pressure. All right, everything is increased there because there's a decreased compliance. Okay, the plateau pressure is high, the peak pressure is high, the what's it called? The peak plateau is also high, the same thing here, but you'll find out that the difference between the peak pressure and the peak plateau is the same because they increase pari passu. For the flow time waveform with decreased compliance of the respiratory system, you have increased peak expiratory flow rate, all right, and shortened expiratory time. All right, auto PEEP and air trapping. I just like to bring this in for us to just understand. So what is auto PEEP? This is positive end expiratory pressure caused by progressive accumulation of air. All right, at the end of expiration, the alveoli should be empty. But when there is progressive accumulation of air in the alveoli, it's called air trapping, and this makes inhalation inadequate, all right, prior to the initiation of next breath. So before the breathing is switched from expiration to inspiration, you still have some air trapped in the alveoli. So what are the causes? Insufficient time for expiration, all right, or there could be early collapse due to unstable alveoli during expiration. Instead of them to wait for air to be removed, they collapse and trap air inside. All right, so how do you notice this on your waveform? You see that the waveform rises above baseline during expiratory hold. During inspiration, the waveform rises above the baseline. It shows you that there's air, all right, residual air. In flow wave, the expiratory flow does not return to baseline before the next breath. And for volume waveform, the expiratory portion does not return to the baseline too. So how do you manage auto PEEP and air trapping? You go to your ventilator and change the setting, to increase expiratory time while you're decreasing respiratory rate and tidal volume. You want to reduce ventilatory demand, then sometimes you may need to just increase your sedation, or you want to bring the muscle relaxant on board. All right, in case of reduced flow resistance, you want to use large endotracheal tube, regular suctioning, and you may also want to bronchodilate the patient's airway. Another thing is to counterbalance respiratory flow limitation by applying external PEEP, positive end expiratory pressure from your ventilator. All right, that pushes the air in the alveoli out. So patient ventilator asynchrony. This is a very common finding in our ventilator patient. All right. Normal patient ventilator synchrony occurs when there is understanding between the ventilator and the patient. All right, so synchrony normally occurs when ventilator starts inspiration at the same time of onset of patient's inspiration. So they're synchronizing. So the flow provided by the ventilator meets the flow demand of the patient. The ventilator inspiratory time matches with the patient inspiratory time, so they are in tandem. But when they are not in tandem, when the patient is breathing against the ventilator, they are not synchronizing. We call it patient ventilator asynchrony. And there are different causes. It could be due to trigger synchrony. So there could be auto-triggering. There could be ineffective delay or double triggering. So the ventilator senses that the patient is asking him to breathe, and the patient breathes and delivers the ventilator breaths. All right, so there's asynchrony. There's circle-asynchrony. That is, circle is when you're turning from inspiration to expiration. Or there could be flow asynchrony. There could be high demand for flow by the patient, but the ventilator is set at a very low flow rate. So, like I said, it's a common phenomenon, and of course, at the rate of between 10 to 85%. It could be due to patient factor, it could be due to ventilator, it could be to both. The most common types are those that are really tricky, like I mentioned before. And each of these types can be detected by visual inspection of the volume, flow, and pressure waveforms on the ventilator display. So how do you manage patient ventilator asynchrony? One, you want to ensure what is causing it. The underlying cause must be sought and treated. So you want to control patient's anxiety, pain, all right? You want to deepen sedation. Well, sometimes you need to, because deepening sedations may actually reduce patients leaving the ventilator, and that can give you what's it called, trigger asynchrony. Well, the best way is to use ventilation modes that ensure synchrony between the patient and ventilator. And proportional assist ventilation and neurally adjusted ventilatory assist mode are the best modalities to reduce patient ventilator synchrony. And there are a lot of unwanted outcomes, like I mentioned before here. You can see them on the slide. All right, so these are references. And, if you have questions, you can ask right now. Or if you don't have questions, I will ask you questions. Elizabeth, you're always the first.
Intense. No questions now, Prof. Just need to revise again.
You people get the recording. I sent the recording to you. Did you people get the recording?
No.
I sent the recording of the lectures.
I received them, I think.
Yeah. Why is Elizabeth not receiving them? That was any question?
I wasn't so sure about the Tobin's index, but I think I'll go read it up again and get some clarity on it.
No, let's
because I don't know whether you said you need to to take the
I can't hear
frequency.
you. Your volume, I mean, your.
Is it better now?
Yeah, it's better now.
Okay, no, I'm saying I just wasn't sure about the Tobin's index when you checking whether the patient is fit for extubation or not. I wasn't sure whether it is frequency, the frequency of the respiratory rate divided by the tidal volume that's supposed to be
Yeah, it's
less than
frequency,
100.
respiratory rate, actually. It's respiratory rate over tidal volume.
Divided by the tidal volume.
Yeah, tidal volume in liters.
Okay, but if you are putting the patient on a T-piece, how will you get the tidal volume?
No, the tidal volume, sometimes what's it called? You measure the tidal volume by using, what's it called? Sometimes the best thing is to actually do it with the patients on ventilator, because it gives you, especially patient on pressure support. There's a way you can actually measure the patient's tidal volume on T-piece, especially with, what's it called? This blowing of, what's it called? Inspiratory spirometry. The patient breathes into the spirometer and it measures the tidal volume.
Okay, and you do it after you wean the patient off sedation as well.
Yes, obviously. You want to do Tobin's index registered by weaning off the patient off ventilation. I mean, off sedation rather.
Okay, thank you, Prof.
Yes. Aqua. Aqua.
Yes, Prof.
Any
Thank you,
questions?
Prof. No questions, Prof.
Ivo Olan, the first person to come to class today.
No questions from my side, Prof.
Okay. Julia Kapofi.
I have no questions, Prof.
Okay. Sudan. Nicole. Nicole. Nicole and Sudan, where are you people? They are busy doing other things.
I said
Okay.
no questions, Prof.
Okay, I just heard you now.
Thank you.
Okay, so if there are no questions, let's call it an evening. Let's prepare. Let's go prepare for our case presentation. See you on Thursday.